Okay, today our lectures for clinical pharmacy. This is the clinical and pharmacological characteristic of drugs for the treatments of the genital disorders, pharmaceutical care. These lectures will have the two part. First part, clinical pharmacological characteristic of drugs for the treatments of the disorders of the female sexual sphere, pharmaceutical care. Now, for the first prevalence of the disorders of the female sexual sphere, report of the frequency of the psychosexual difficulties from the diabetic women found secondary sexual dysfunctions was reported maybe 73% of diabetic women. However, no direct associations between the sexual disorders and diabetic complications were found. Currently, there are few pharmacological options available in the treatments of the FSD, female sexual dysfunctions. Historically, FSD patients were treated through psychological therapy. However, we have come to understand the extentiveness of the disorder. More basic science research and clinical recognitions have been developed to address the problem. Severe pharmacological initiatives are in developed aim at increasing blood flow to the genitals, improving androgen deficiency, and enhancing central nervous system stimulation. First group, that is the phosphodiesterase 5 inhibitors, increasing blood delivery to the genitals with the developments of the first marked PDA 5 inhibitors. Sildenafil revolutionized the treatments of erectile dysfunctions in men. Their psychological mechanism responsible for the relaxations of smooth muscles of the cavernous tissues, both male and female, is initiated with the relax of nitric oxide from adjacent nerve ending and the endothelial cells upon mental and the sensory stimuli via spinal reflex. Nitric oxide produced by the sexual stimuli passes through the plasma membrane of the smooth muscle cells and binds to the guanyl cyclase and soluble guanylate cyclase. Phosphodiesterase type 5 inhibitors reduce the catalysis of the cyclo-GMP by PDE5 and therapy increase the cyclo-guanyl cyclase availability. Other recent reviews article regarding no signal may be useful for understanding additional aspect of this mechanism. Very interesting fact. Usually these drugs we like to prescribe for the men, but severe PDR inhibitors, sildenafil, vardenafil, tadalafil, are available for the treatments of erectile dysfunctions in men. Through success, the PDE inhibitors in males with the sexual dysfunctions did stimulate interest in treating female sexual dysfunctions. The same effectiveness of this drug class has not been found across genders. Early clinical trials conducted by questionnaires in women with the disorder, sexual disorder, showed some promise, revealing that sildenafil improved the ability to achieve orgasm and state of arousal. Vardenafil, taldenafil, Levitra, Viagra, sildenafil group, practically very popular drugs for the treatments, not only disorders in men, but we can use these drugs in women group. For example, the Kalvanitsati, the scientist, showed the sildenafil significantly improved clitoral blood flow in postmenopausal women with orgasmic dysfunctions measured by collar and pulse Doppler. Next group, prostaglandins. Prostaglandins are found in virtually all tissues and organs. They are autocrine and paracrine lipid molecules which are quickly metabolized, maybe during the some seconds, some minutes in peripheral tissues, and participate in a variety of the physiological events, including blood flow regulation. Specifically, the prostaglandin is a form PGE1, prostaglandin E1, signaling through its EP2 receptors, cause smooth muscles relaxations in the vaginal, uterine, and as well as penile smooth muscles. Prostaglandin 1 and EP2 activation leads to increase of the circulated aminotransferase, resulting in the actions of the protein kinase A, which causes smooth muscles relaxation. Prostaglandins has been used in male sexual dysfunctions, especially erectile dysfunctions, administered through penile injection for some times and have displayed positive outcomes for certain women with the genital sexual arousal disorders, most likely through increasing the vaginal secretions and arterial smooth muscle relaxation. Prostaglandins. Next variant, the synthetic versions of the prostaglandin E1, alprostadil femprox, has displayed positive results for the treatments of the female sexual dysfunction. Administered topically, therapy not resulting in systematic side effects. Applications are alprostadil demonstrated positive response in genital vasoconstriction, vaginal erythema, and transudate volume. However, these effects were not consistently superior to placebo effects. In a recent randomized double-blind placebo-controlled study, 400 female patients pre- and postmenopausal period with the sexual disorders, displayed an improved sexual arousal rate when topical alprostadil was applied prior to vaginal intercourse. Although topical alprostadil is a potential new therapy for the treatments of the disorders, more conclusive results from ongoing clinical studies are needed to further validate the use of topical alprostadil in the treatments of the female sexual disorders. Nitric oxide donator and combination therapy. It is well established that the production of the nitric oxide is essential in vascular relaxations to the numerous stimuli. The phosphodiesterase 5 inhibitors augment nitrooxidase initiated deletions by propagating the downstream mediator, cycloguanyl monophosphate, through the activations of the guanylate cyclase. Thus, activations of the nitroxide synthetase systems is a potential site for the pharmacological intervention. Feature demonstrate topically applications of the nitroxide donor, DS1, a linear polyethylenamine nitric oxide nucleophile addict, increased vaginal blood flow in the all anesthetized rates. Some nitroxide donor creams are available since SUE. However, these topical therapies have yet to become FDA approved. Nitroxide independent stimulations and activators of the guanosine synthetase, including the BA and other experimental drugs, have shown the ability to improve erectile functions in rodents and could be targeted towards the treatments of the female sexual disorders as well. Combination therapy, L-arginine, and substrate of the nitric oxide productions, yohimbine, and competitive alpha-2 adrenergic receptors antagonist, nitromate, has completed phase 1 and 2, second A clinical trials. However, trials have not been continued and the current stage of the product is unknown. Two additional alpha-adrenergic receptors antagonist, phenylamine, not selective alpha-adrenergic receptor antagonist, as well as the I-adrenergic receptors antagonist, have begun clinical trials, but their current study is uncertain. Another energy product, arginine max, has demonstrated positive results in the treatments of the female sexual disorders. During the 4-week placebo-controlled study, women in the peri or postmenopausal state who reported lack and sexual desire of exhibited statistically significant increase in clitoral sensitivity, sexual satisfactions, increased frequency of sexual intercourse, and decreased vaginal dryness compared to women in the control group. The author report that the change in the sexual satisfactions and elevated state of desire were stronger in the premenopausal and less in the postmenopausal group, potentially due to the alterations in the hormone levels. Ergin Max is a nutritional supplement, continue extract from the ginseng, ginkgo, demonia, arginine, and include various vitamins and minerals, and further scientific investigations of the natural enhancement compound is needed. Vasoactive intestinal peptide, VIP, is a polypeptide hormone containing the 28 amino acids residues and is produced in many areas of the human body. VIP has potent vasorelaxant effect and has been suggested to contribute to the vaginal blood flow control. Like many peptide therapies, oral administrations of the VIP is complicated by a low bioavailability and high rate of clearance. Therefore, an alternative approach using of the inhibitors of the natural and the peptidase, the primary enzymes responsible for the degradations of the VIP, has been in developed under the assumptions that inhibitors of natural and the peptidase will lead to more VIP in the circulation, which can increase clitoral and vaginal blood flow when sexually stimulated. Pfizer has developed through the cardiovascular agent candoxatrilat, a diacide of the NAP inhibitors, which requires the delivery is the prodrug form candoxatril to assure their systematic exposure. The inhibitors, as well as dual inhibitors of NAP and soluble endopeptidase, has been demonstrated to inhibit NAP-CIP mediated degradations or VIP and could potentially aid in the treatments of the female sexual disorders. However, there are not current data demonstrations the effectiveness of this agent in improving clitoral of the vaginal blood circulation. Estrogen group, very popular group for the corrugations of the female sexual disorders. Estrogen plays a vital role in the regulations of the female sexual dysfunctions. Alterations in estradiol levels can result in vaginal wall, smooth muscles, atrophy, and increased vaginal canal acidity, ultimately leading to discomfort and stress. The finding from the Women Health Initiative raised concern on estrogen replacement therapy. However, the benefits of estrogen in normal functions are well accepted. In the treatments of the female disorders, Vegiferm or Premarin have been shown to improve vaginal dryness and irritations. Interestingly, it does not appear that these products specially delivers estrogen solely to the genitals. Labre and the colleagues recently demonstrated that following the one-week treatments of the Vegifem or Premarin, these compounds caused as approximately 5-fold increase in serum estradiol and postmenopausal women. Vegifem, that is the 25 nanogram conjugated estrogen vaginal cream. Estrogen, please, okay. Tibolone is an additional hormonal modulator options. It is a synthetic steroid commonly used for the treatments of the menopausal symptoms, including the diminished vaginal lubrication. Recently, scientists of the New Zealand and colleagues demonstrate that tibolone 2.5 milligram treatment improved overall sexual functions, increased frequency of the sexual events, and reduced sexual-related personal distress in natural postmenopausal women with a sexual dysfunction. Tibolone 2.5 milligram. Centrally mediated stimulations. The sexual response for men and women of the is distinct. Regarding treatments of male with the PED, AD inhibitors have proven to be very successful, whereas the FSD similar achievements have not been made. Treating family dysfunctions through central actions mediators has recently received more attentions. This area of investigations has gained momentum. The recent publications demonstrations that several hypothalamic nuclei are activated in the rodent sexual response. Therefore, central regulations, activations of the female sexual response could mark an alternative approach for the treatment of the FSD. A central player in behavioral states, including sexual functions, that is, the dopamine signals through its receptors, are mediated, are variatory to response. Dosing limitations in apomorphine and bupropion administrations has reduced effectiveness of this therapy as high exposure leads to adverse side effects such as nausea, vomiting, and headache. The use of the apomorphine in women showed increase the sexual responsiveness. Through patients involved still reported unwanted side effects. New administrations therapy, especially intranasal and sublingual distributions, have reported equal effectiveness in the increase of the sexual desire while they're minimizing side effects. Additionally, intranasally delivered apomorphine in male rates significantly increase brain distributions and accumulations of the dopamine agonist, which leads to the faster and more efficacious of the treatments of the option. Another central action agent that has been in the development in the recent year is a melanocortin stimulation hormone. That is the 13 amino acids peptide, which signals through its receptors located in the brain, in the more specifically in the paraventricular hypothalamic nucleus. Recently, Agon and colleagues demonstrate that melanocortin stimulation hormone relaxed both vaginal strips and vaginal arteries from rats. Experimental interesting works. Bremelanotide is a synthetic analog of the melanocortin stimulation hormone that shows highest binding affinity for the MC4 receptors. However, is reported by Ogon and colleagues, the endogenous form of the melanocortin stimulation hormone was much more effective in relaxing rabbit vaginal wall and vaginal arterial smooth muscles than the bremelanotide. Well, that is the bremelanotide injections, 1.75 milligram combinations with other drugs. Administrations of these central action agonists varies between the oral, intranasal, or sublingual. Intranasal appear to be most effective delivery method. That is the changes of the pharmacokinetic way of introductions of the drugs. Method where the oral administrations results in unwanted side effects such as vomiting, nausea, and headache. Testosterone hormones. Key endocrine hormones, estrogen, progesterone, and testosterone, are involved in the sexual response and the deficiency. In the level of the androgen potential are involved in the female sexual dysfunctions. Low levels of the testosterone are associated with the decline of libido, arousal, genital sensations, and orgasm. The use of the testosterone to treat female sexual dysfunctions has delivered mixed results. A primary concept of the testosterone therapy is the long-term side effect, including hirsutism, acne, and masculinization. Given the results of the following of the Women Health Initiative, replacement therapy with the estrogen and progestin related elevations, in coronary heart disease, stroke, and thrombosis formations, a certain amount of the caution must be taken into the treatments of the female sexual dysfunctions with hormones. Testosterones. Practically very interesting drugs, which is the transdermal testosterone in transa. The patch placed just below the navel has been shown to produce an increase of the sexual activity and pleasure in the 6-month study trials. Severe dose of the testosterone were examined during the clinical trials, 150 to 300 and 450 picogram per day. However, the most effective dose, the 300 picogram per day. Intrinsa. Other studies have reported similar results. However, the absorbed changing through the clinically meaningful are considered modern at play at best. Applications of the testosterone by topical cream of gel has been developed as well. Tostrel, Siligy, transdermal testosterone methylated gel that has the completed phase second trials has reportedly restored the testosterone levels in menopausal women. No further information is available on the progress of the products. Additionally, Novavax, Antrosorb, a testosterone cream, is an early stage in the clinical trials and preliminary has shown the high libido of the postmenopausal women. That is the first part. And now we will discuss about the second questions of our patients, which is the clinical and pharmacological characteristic of drugs for the treatments of the disorders of the male sexual sphere. Pharmaceutical care. Types of sexual dysfunctions. Sexual dysfunctions may reflect problems with the following factors: libido, ejaculations, erectile dysfunctions, combinations of the above factors. Reduced libido can result from the organic or psychological causes. It often accompanies a low level of serum testosterone or increased level of the serum prolactin, and these changes may be either primary or secondary. It is also associated with the psychological problems, relation difficulties, medical illness, and use of the certain drugs. Practically, the two main categories of the erectile dysfunctions are psychological and organic. Often, the dysfunctions is of mixed etiological origin, in as much as both factors are important. Every man who has some problems with the erectile dysfunctions develops performance anxiety, and determine whether psychological factors are the main problems of merely and minor accompaniment may be difficult. It is corpora cavernosa cannot expand and fill with blood, decreased erectile firmness occurs. Although atherosclerotic plaques or damage by trauma or radiations may decrease blood flow to the penis, vascular causes of erectile dysfunctions are more often due to the failure of the neural, muscular, or chemical factors. Venous leakage occurs when incomplete filling of the corpora or intracavernosal fibrosis causes failure of the veins to be pressed shut again to the tunica alveolar. Erectile dysfunctions can be impaired as a result of the cerebrovascular accident, that is maybe stroke, transitory ischemic attack, and others, demyelinization disease, or even seizure disorders. Tumor or trauma to the spinal cord can also be causative factors of the erectile dysfunctions. Autonomic and peripheral sensory nerves may be damaged by trauma or transurethral resections of the prostate. A common cause of the impaired erectile and the ejaculation functions is nerve damage attributive to diabetic autonomic neuropathy. The prevalence of the disorders increased by the durations of the disease in both type 1 of type 2 diabetes, and it is more likely to depend when the plasma glucose is poorly controlled. Hormonal perturbations may contribute to sexual dysfunctions, especially erectile dysfunctions. Most such problems resolve around dysfunctions of the hypothalamic pituitary gonadal axis and are associated with either excessive prolactin and decreased testosterone levels. Other endocrine disorders that may be associated with the impairment of the libido or erectile functions include the hypothyroidism, hyperthyroidism, adrenal insufficiency, or excessive levels of the adrenal corticosteroid, syndrome of Cushing disease, Cushing syndrome, and others. In such causes, patients may experience a generalized fatigue of weakness from the effect of the illness. Tumor of the hypothalamic pituitary area may cause hypogonadism by mass effect, distractions of normally pituitary tissues, or oversecretions of prolactin, which may suppress gonadotropin and cause secondary hypogonadism. In these situations, we like to prescribe the MRI verification. Sometimes we find the microadenoma, macroadenoma, more if the tumor size more than 1 centimeters, 10 millimeters. And the first clinical symptoms, hyperprolactinemia. That is the very, very pathognomonical clinical symptoms of immense of tumor disorders in the hypothalamus hypophysis. Well, that is the scheme of the activations with gonadotropin hormones. That is the one of the 6 hormones from the adrenal hypophysis, and these disorders, that is the one of the pathogenesis of the male sexual dysfunction. Medical conditions. Any medical conditions that can cause general debility has the potential to decrease sexual desire and the performance, pain, shortness, or breath, angina, muscle weakness, and maybe cardiovascular disorders may be responsible for the dysfunctions. The most common medical conditions associated with the sexual dysfunctions are diabetes mellitus or hypertension, possibly because of the microvascular and neurovascular changes that are inherent in these conditions. The patients with the diabetes, these factors may lead to the decrease in the penile nerve stimulations and in the generations of the nitric oxide. Some investigators have found hypogonadism to the commonly associated with the diabetes mellitus. Fully contrast plasma glucose level add to the separate risk as does the presence of the diabetic neuropathy. Not only is the hypertension a separate risk factors for the sexual problems, but hypertension and diabetes often coexist in patients, comorbid factors practically. That is the scheme, this effectiveness of the diabetes to the brain, to the fat, to the muscles, to the heart, kidneys, and results of these and nervous systems, peripheral nervous systems, and these factors, combinations of these factors provocate of these male sexual dysfunctions. Generalized atherosclerosis and peripheral vascular disease may impede blood flow to the penis, as may damage vessels attributed to the pelvic injury of radiation therapy to the groin. Recently, the cardiologist reported in the assessment of 50 men who presented with the erectile dysfunctions but who had not history of cardiac disease. Most men had multiple cardiac risk factors, and maybe 56% had asymptomatic ischemic changes on the treadmill test consistent with the silent ischemia. Because erectile dysfunctions and cardiovascular disease share common risk factors, erectile dysfunctions may be a predictors of the future cardiovascular disease. A search of the cardiovascular risk factors was suggested as a part of the evaluations in men with a sexual dysfunction. Both prescriptions in and over-the-counter medications have been shown to be a cause of the erectile problems in as many as 25% of cases. Although single medications can induce the erectile dysfunctions, the adverse effects of the medications are often additive. These situations are particularly frequent in older men who are taking multiple medications, and partial or complete erectile dysfunctions often result. A psychological component can make partial erectile dysfunctions progress to complete erectile dysfunctions. Some medications can affect libido, whereas over the affect erectile functions or ejaculation. Non-prescription medications, such as antihistaminic or the decongestant, may also impair erectile dysfunction. Most psychotropic drugs can affect libido or erectile functions, either through a direct action or by increasing prolactin or decreasing the testosterone level. Although antidepressants may cause erectile dysfunctions in susceptible patients, they may also be beneficial in improving libido in depressed men. Antihypertensive medications may cause erectile dysfunctions either by drug-specific effect or by decreasing the systolic blood pressure and therapy decreasing the intracavernosal penile pressure. Now, for example, the carvedilol, atenolol, maybe that is the most aggressive drugs for the decreasing of the erections in men, and sometimes we must change their group for the prescriptions of the beta blockers for the men to the another group, for example, calcium channel blockers or AC inhibitors or the sartan groups, because that is the serious side effects for these patients. The effect of especially prevalent of patients with the diabetes or the hypertension who have the underlying microvascular disease. Another aspect, pharmacokinetic interactions between the drugs. For example, we must remember about the ketoconazole, aminoglutamide, and similar drugs actually decrease the production of the testosterone. Most of the early antihypertensive agents, such as rezapine, guanidine, and hydralazine, cause sexual dysfunctions. You will have the questions in the CROC2, for example, what drugs has the effect to the decreasing of the blood pressure, and we can and we like to prescribe these drugs for the treatments of the adenoma of prostate of men. That is the doxazazine correct answer. We can to prescribe in men's group with the sexual and prostate disorders. Some adrenergic blocking agent may cause sexual problems, but dysfunctions with the angiotensin converting enzymes inhibitors of calcium channel blocker is less common. Some drugs, spironolactone, cimetidine, flutamide, and cypraterone acetate, may block the peripheral androgen receptors. Cimetidine may assume of the great importance because it can now be purchased without the prescriptions. Drugs such as the methyl-dopa, spironolactone, digoxin, metoclopramide may raise prolactin level. Thiazide-diuretics, finasteride, anticholinergic agent, and pain medications can cause erectile dysfunction. For example, ketoconazole, which is the very aggressive inhibitors of the CYP3A4, these drugs can increase the another drugs, concentrations of the another drugs in the blood, but the depressing effect of these drugs, which is the antifungal treatment, ketoconazole, intraconazole, and others, depress of the synthesis of the testosterone and induce sometimes during the long time using induce them male sexual dysfunctions. Hydralazine, rezapine. Hormonal treatment. Behind the prostatic hyperplasia, prostate cancer, sleep apnea, and polycythemia may be evaluated before the after initiations of the testosterone therapy for the hypogonadal men. A baseline, a digital rectal examinations of the prostate and the prostate-specific antigen level, and a hematocrit should be determined before treatments. If any prostate-related abnormalities are detected, the patient should be referred to the urologist for the further evaluations. Any patients treated with the replacement androgen should be resisted within the 1 to 3 months after initiations of the therapy, and then in the 6 to the 12 months intervals to ensure the clinical problems have not developed or worsened during such treatment. Well, that is the classic drugs from this group, testosterone propionate for intramuscular injection. Prostate cancer and breast cancer are contraindications to androgen therapy, whereas the sleep apnea, peripheral edema, erythrocytosis, hematocrit more than 52%, and benign prostatic hyperplasia are relative contraindications that they may respond to adjustments in the medications or specific treatments. For example, use the continued positive airway pressure or airway gain reduction. Testosterone replacement therapy for hypogonadism may also correct sexual dysfunctions unless the patient has other comorbid illness. For decided the standard has been a depot intramuscular injections of the testosterone, enantanate, of propionate, of cipionate, every 2 or 3 weeks, 200 milligram or 300 milligram respectively. Smaller dose and more frequent injections, however, are better of the maintaining circulation testosterone levels in the normal range. That's the 50 to 150 milligram of the testosterone and on top of the cipionate intramuscular injections at 7 or 14 days intervals. An alternative approach is administered the 100 milligram on day 1, 11, or 21 of each month, while allowing some flexibility of injections days. If testosterone levels are measured, they should be in the normal range just before the next injections. Other forms of the intramuscular testosterone preparations are also being evaluated. Implantable testosterone pellets, which are used in other countries, are not available in the US, but they are frequently prescribed. Currently available tablets for oral administrations have generally not been used because of the potential liver toxicity. And neither oral capsules testosterone andeconide has been used for more than a decade in the Europe, but has not yet been approved for use in the US. Although the safety of not questioned, multiple daily doses are required and the absorption is erratic. Other orally and sublingually administered testosterone tablets are being evaluated. Testosterone, scrotal and the non-scrotal dermal patches have been approved by the US Food and Drug Administration, FDA. Testosterone absorption is the greater through scrotal skin. The scrotal patch was the first for the introduced. These patches are placed on the scrotal skin and other changes daily in the morning. For many patients, weekly shaving of the scrotum is necessary. The patch increases the testosterone level to the few low normal range, which peak levels are achieved 3 to 5 hours after applications of the patch. And because the 5A reductase in scrotal skin is high, the dihydrotestosterone level in serum becomes quite high. The role of the dihydrotestosterone is currently being investigated. The non-scrotal patch, for example, androderm, applied daily in the evening, may be worn in various sites on the skin. The manufacturers recommended that it not be used over bony prominence. The levels remain stable in the middle of the normal range, and the DHA level remained normal. Skin irritations may be developed and often responds to applications of corticosteroid cream. In a certain small percentage of the patient's therapeutic blood level of testosterone may be not achieved. Another non-scrotal patch, for example, testoderm, was associated with less skin irritations but was more likely to fall off. It has recently been withdrawn from the market. Well, for that is the simple of the androderm testosterone transdermal systems 2 milligram, androderm 4 milligram of the testosterone, that is the testosterone transdermal systems. And 1% testosterone gel has recently been approved by the FDA for use in the US. It is more expensive than the testosterone patches. The blood level of testosterone associated with use of the gel are dose dependent, the very less than with the testosterone patches. care must be accessed because the testosterone can be transferred to another person to skin contacts occurs. With any form of the testosterone treatments, the patients may have a slow but steady increase of libido and erectile ability during a course of months. If no improvement is noted after the 3 months, the hormone deficiency is probably not the only causes of the sexual dysfunctions. A comorbid medical illness might be present, or perhaps performance anxiety is dominant. The hypothalamic pituitary gonadal axis has been shown to the decrease of the functions temporarily after acute medical events of surgical procedures. Such an occurrence can cause low gonadotropin and testosterone levels. Similarly, a temporary decrease in testosterone level may occur as a result of less serious circumstances such as the anxiety, excessive intake of alcohol, use of the multiple medications, or uncontrolled diabetes. Patients with these causes are less likely to respond to the testosterone replacement. Stimulations of the gonadotropin with the clomiphene citrate or the subsequent increase in testosterone levels emphasize the functions and the reversible nature of the phenomenon. Short-term therapy with the clomiphene citrate may be help some patients. Some patients don't respond to the aforementioned corrective measures and with wish to try non-specific therapy for erectile dysfunctions. This scenario might especially exist in older men and those with numerous medical risk factors. The major options to consider of the present time of the yohimbine tablets, vacuum pump devices, venous constriction rings, corpora cavernosal injections of the various chemical, intrauretrical drug suppositoria, intrapenile arterial or venous surgical procedure, penile implants of oral administered phosphodiesterase inhibitors. Trials with the sublingual administrators, apomorphine, and vasodilatators are ongoing. No, they're just the classic drugs for these problems, for treatments of these problems, yohimbine, for example. And sildenafil has recently been approved by FDA. It inhibits phosphodiesterase type 5, which predominates in the penile tissues. The actions prevents of the breakdown of the cycloguanosine monophosphatase, which therefore increases smooth muscle relaxations in the corpora cavernosa and enhances the penile rigidity. 3 doses available: 25, 50 milligram of 100 milligram. If the patient does not have the hypogonadism and has no contraindications to use of these drugs, a clinical trials with the sildenafil is indicated. Treatment is usually initiated with the 50 milligram tablets, which decrease to the 25 milligram of major side effect are noted, or increased to the 100 milligram if they're the lack of the efficiency. Sildenafil, classic drugs, Viagra, very popular drugs and effective for men and sometimes for women. The tablets is taken 1 hour before the sexual activity and sexual stimulations is necessary. Sildenafil is contraindicated in patients taking nitrates, if any form, in as much as severe hypotension and resulting the syncope have occurred. Side effects are generally mild and tolerable. Headache, sometimes hot flashes, heartburn, diarrhea, myalgias, hypotension, and dizziness. The drugs may be inhibits phosphodiesterase type 6 in the eye with the results of the difficulty of the discriminations blue from green, blushes, tones, and visions, or difficulty seeing in dim light. When any adverse effect occurs in diabetic retinopathy or another eye disease is yet to be determined. Yohimbine is derivative of the African yohimbine trees, has been available for the severe decades. This alpha-2 antagonist is effective in some cases of the psychological and high erective dysfunction, but it's effectively of the controversial. The tablets is available is one strange 5.4 milligram, and the standard dose is the one tablets 3 times a day. If this patient has a response, it will generally occur within the first 4 weeks. A short course of 2 tablets 3 times a day may be tried, but the increase of the respondents will be small. Severe spots have described a positive response over placebo in patients with a psychological erective dysfunction. Major side effects are uncommon, but minor symptoms, including the headache, dizziness, insomnia, and anxiety, may occur maybe 25% of cases during the first week of the treatments. Patients who have blood pressure that is difficult to control might notice that the pressure increase. The additionals of trazodone to the treatments regime has increased the number of the responders, but also increased the number of the potential side effects. Trazodone has been shown to be useful alone, especially in men without non-organic causes for erectile dysfunctions, in doses maybe from the 25 to 200 milligram per day. The increased nocturnal penile activity seen with the regime provide objective evidence of the improvement unrelated to any potential placebo effect. The main provisions of the standard for the treatments of the erectile dysfunctions. Men presented with the symptoms of the erectile dysfunctions should undergo either through medical, sexual, and psychological history, physical examinations, and selective laboratory testing. For the men with the AD, validations questionnaires are recommended to access to the severity of the erectile dysfunctions, to the measure treatment's effectiveness, and to guide future management. Men should be counseled that the AD and the risk marker for the underlying cardiovascular disease and other health conditions that may warrant evaluations and treatment. In men with the AD, morning serum total testosterone levels should be measured. For some men with the dysfunctions, erectile dysfunction, specialized testing and evaluations may be necessary to guide treatment. For men being treated for the AD, the referral of the mental health professional should be considered to promote treatments adherence, reduce performance anxiety, and integrate treatments into the sexual relationship. Clinical should be counsel men with the AD who have the comorbidities know that negatively affect erectile functions, that lifestyle medications, including changes in the diet, increasing of the physical activity, improve overall health, and may improve erectile function. And men with the erectile dysfunction should be informed regarding to the treatments, options of the FDA approved oral phosphodiesterase type 1 inhibitors, sildenafil, for example, including discussions of the benefits and the risk burdens unless contraindicated. When men prescribe the oral phosphodiesterase inhibitor type 5 for the treatments of the erectile dysfunctions, instructions should be provided to maximize benefits efficiency. For men who are prescribed this group of the drugs, the dose should be titrated to provide optimal efficiency. Men who has the degenerate professions of the erectile dysfunctions after the treatment of prostate cancer by radical prostatectomy or radiotherapy should be informed that early use of the phosphodiesterase inhibitors type 5 post-treatments may be not improved spontaneous in the erectile dysfunctions. Men with the erectile dysfunctions and testosterone deficiency who are considering AD treatments with the phosphodiesterase type 5 should be informed that this group may be more effective if combined with the testosterone therapy. Men with the erectile dysfunctions should be informed regarding the treatments, options of the vacuum erections device, including discussions of the benefits and risk burdens. Men with the AD should be informed regarding to the treatments or options of the intra-urethral alprostadil, including discussions of the benefits or risk burdens. For men with the AD who are considering with the use of the intra-urethral alprostadil, and in-office tests should be performed. Men with these dysfunctions should be informed regarding the treatment options of intracavernous injections, including discussions of the benefits and risk burdens. For men with the erectile dysfunctions who are considering AC therapy and in-office injections, tests should be performed. Thank you for your attention. Thank you.